What is up, everyone? My name is Haney Malamat, and I'm here with that guy. It's actually this way, Dr. Adam Green. What is up?
Haney, how you doing, man? I got a feeling. I think tonight is the first episode with no computer glitches. That's what I'm feeling. I'm calling it right now.
You realize that you've completely now just jinxed this entire program by saying that, right? You never say.
You're
You
That's
know
right.
that by
You're one of the
working the
black
SEO.
cloud. You're one of the black cloud guys, aren't you?
Well, I just know that there are certain things you say and certain things you just kind of look past and you keep going. But what do we have tonight? What are we talking about?
I'm going to give credit to our buddy Randy because when I told him the topic, he said, Actually, you know what? I'm going to pull it up so I don't misquote. He said, the sworn enemy of undifferentiated sepsis,
Which is
the
the
gallbladder.
gallbladder, right?
So,
And for those of you, the listener that views us, that Randy is an actual person, not just a reoccurring character, but he's been on every episode, and one day we will get him on here to be part of the show. But so Randy wanted this episode. This is for Randy.
That's right. That's
This
right.
this
Acute
episode is
cholecystitis. Acute cholecystitis for the intensivist. So I'm thrilled. I think
all
it's going
right,
to be
and
great.
we have some special guests on. This is the first time that we don't have any intensivists on the program. Is that right?
That's right. That's right.
All right.
That's
Well,
right.
enough is enough. Let's just bring these very special guests on, and I'm gonna let you do the introductions.
Sure. As always. So we have two Cooper attendings. We have Dr. Amin on my right. Yep. Who is the head of the IR department, and then we have Krysta, Dr. Contino, there on the left, who's a gastroenterologist, Cooper trained. And so, thank you to both of you. I'll say it now for taking the time to chat with us.
Absolutely. Happy to be here.
What else did I miss? Is there anything else we need to know about you?
They're not gonna say anything because
Oh,
they're two humble people, but I'm gonna say it. These are two people that when things are really bad with your patient, it doesn't matter the time of day, the day of the week, the year, even on a leap year, you call them up and they're going to do what it needs to take to get the patient well. And I mean that sincerely. Both of these ladies have helped me out when I've been really stuck with my patients. So these are the people that I want to bring on because they just know how to manage this disease and they're going to do what it takes to make sure that our patients have the best shot. So that's who they are. I'm putting it out there.
that's right. That's right.
It's only because you're calling at 3, because otherwise 3 in the morning is not a good conversation time.
Well, I'll take it. I appreciate that. All right, well, let's get into it. Adam, you want to kick it off with the first question?
Yeah, I think unlike other topics, there's just a lot of terminology. There's a lot of names that all kind of sound the same, and no one knows how to spell and no one knows how to pronounce it. And so I think maybe we'll just keep it simple and kind of see where things go. So talk to me about the difference. Maybe we'll start with you, Krista. The difference between acute cholecystitis and cholangitis. Are they interchangeable? If you have one, do you always have the other? How does that work?
Yeah, so good question. I think this is probably a good differentiation point to at least start with. So you have the gallbladder, you have the biliary tree, two very different things anatomically that we address. From a GI perspective, we worry a lot about the biliary tree. That's when we talk about interventional gastroenterology and going in and removing stones that become lodged within the bile duct. That's more the GI side of things. We have cholangitis, which cholangitis is really when you have obstruction of that biliary tree, and we need to really relieve that obstruction in order to help treat the patient. Cholecystitis is when you have inflammation of the gallbladder itself, which generally people will present more with abdominal pain, fever, leukocytosis. It's when you hear about the Murphy sign, the right upper quadrant tenderness. The cholangitis portion of this, you're looking for fever, right upper quadrant pain, and elevated bilirubin. So you have more of that obstruction when you're looking at actually at the bilirubin being elevated. That's telling us more that there's actually a blockage within the bile duct itself, or the biliary tree, I should say.
So let me ask you this, because I remember distinctly my first rotation, third year medical school, was surgery, and ascending cholangitis was just always bad. Like, you get that consult, it's just always bad. But my question is, can we give it a specific definition? Because, we have varying degrees of learners on here. And then, is it really as bad as it sounds, or do you have time? Are there other things you should be doing when you get the call for ascending cholangitis?
Sure. So ascending cholangitis is one of those things that's considered one of those GI emergencies. So you always hear about people bleeding and bleeding being the emergency, but ascending cholangitis really is, a major issue. So you don't have a lot of time to act on it. You really want to try to decompress the biliary system within 12 to 24 hours. So in terms of definition, you're looking for jaundice. So you're going to have an elevated bilirubin. You're looking for fever, and you're looking for right upper quadrant pain. When you get to the point of hypotension, that's when you're dealing with more of a septic picture, and things really escalate, particularly in the elderly. We have to worry about this even more so. Generally speaking, you're dealing with gram-negative rod infection, anaerobic infection, and trying to really get in there and remove any type of obstruction is going to be kind of the mainstay of treatment. Aside from the treatment of the sepsis with the fluids and antibiotics and so forth. But it is something that when we are able to make that diagnosis, you need to move forward with the treatment, which is biliary decompression.
And Sabina, let me just ask you this. Is there a point where ascending cholangitis is an interventional disease versus an endoscopic disease, or is it whoever can get first? Give me some sense of who makes that determination, or do you guys just flip a coin?
Sometimes I feel like we flip a coin. In all sincerity, I think on either side, we're usually called, whether it's the gallbladder or the biliary system. Ideally, if you can use the body's natural way of going in, i.e. an ERCP stent, that's what we like to see. That being said, that's not always the safest. It's not always anatomically possible after you've got kind of gastric surgery or bariatric surgery. Sometimes there's no easy way to get there. So IR does get involved in cholangitis and cholecystitis, obviously speaking, but cholangitis, ideally for us, we like to see dilated biliary ducts, and we can actually hit those pretty easily. If it's a non-dilated biliary system, ideally that should be a GI thing, because they're probably going to have a better chance at getting into the CPD and kind of fixing that. I think we're both kind of in trouble if it's non-central biliary issues, right? So if it's peripheral ducts in, the outskirts of the left or the right hepatic lobe, we're both going to be in a little bit of a bind. So I think in that sense, it's all hands on deck. But for the most part, if there's an anatomic way to get there and we don't have to create a hole through your skin and through your liver to do it, it's probably the best way to do it. Dilated system, fantastic. Non-dilated, it's a fun challenge day.
Got it. That's very helpful. Thanks.
Let me ask a follow up though. I'm just sitting here trying to think about the difference, right? So, a stone obstructs, there is decreased drainage, bacteria reflexes up. So you go from some cholangitis to cholecystitis, right? I'm assuming most cholecystitis where the gallbladder is infected, at some point, we'll talk about differential. I'll skip that part. And so how, I'm used to calling you when the gallbladder is big and inflamed and they're too sick for Krysta to come in. But when do I know, like, what if the gallbladder's not inflamed, doesn't have edema all around it? Is it still an IR? How does that work?
So I think there's a little bit of a difference between cholecystitis or true just gallbladder pathology and then biliary pathology. And sometimes, yes, the biliary pathology also has acute chole component, but that's not usually what we see. So it's not like you need both things to happen at once. So I think there's a little bit of a difference there. As far as acute cholangitis, we don't really get involved until there's some reason that GI can't do it, only because biliary drains are not the most comfortable drains we put in patients. It's usually through the ribs. It moves every time they breathe. They're miserable for an extended amount of time. So I can honestly say we see a lot of acute cholecystitis because we tend to be kind of the main players on that, as well as with surgery. And then on the acute cholangitis, it's really through a discussion with GI as to why we think this is acute cholangitis, what we can do about it, can we avoid PERC draining them, and going from there. So we're definitely not the first call for acute cholangitis. I think that's usually Krysta's team. That being said, when they've gone so far down the septic shock, I think it's hard to do anything for these people. Septic shock for us, for IR, we see a little bit more often on the grand scheme of things, in the sense of whether it's GI pathology or renal or whatever it may be. We're used to it, except for the fact that putting a needle through a parenchymal organ and distending the biliary tree, which is what we have to do with contrast to be able to see where our wire is going, is not the best idea in a septic patient. So it makes it a little bit more challenging for a non-dilated biliary cholangitis.
Yeah, that makes sense. I was confused there. I don't think I've ever seen a percutaneous tube into
A bile system. Yeah, we do it.
bile
It's
system. Like,
Yeah.
I'm sure it happens, but that was helpful, and so yeah.
begrudgingly we do it, but
Yeah.
we do it, and then
Sorry. I was just going to say, honestly, a lot of times, we get called for the ascending cholangitis, and it can be stone disease, it can be biliary strictures. It's not just stone disease that we end up dealing with ascending cholangitis. So decompression being the mainstay, sometimes technically speaking, especially when there's a large impacted stone at the base of the bile duct, it becomes pretty difficult for us sometimes in order to actually get into the biliary system. And when we fail and we're not able to actually get in, that's when that's when the next call is to our interventional colleagues to help us if we're not able to decompress. So that's, I think, an important point to remember too, is that some of this is stone disease, some of this is not stone disease, sometimes it's cancers, but nonetheless, the whole goal at the end of the day is to decompress.
So this might be a stupid question, but humor me on this one. Does it matter with acalculous cholecystitis when you're approaching this from either one of your perspective, or once you have cholecystitis, then the approach after that is roughly the same?
cholangitis differently, cholecystitis completely different. So I think IR gets involved in almost, I would say, 80 to 90% of cholecystitis here at Cooper. Whether it's acalculous or calculus, theoretically, does it matter for the placement of a PERC chole tube? No. Does it matter for the long-term fixing of the solution? Absolutely. And we can get into that if you want to.
Yeah, that'd actually be great, because sometimes I'll say that some of our colleagues don't want to go in and do anything and wait for the gallbladder to cool down, and that makes some sense. But yeah, I'm sometimes I'm not really following the reason, the logic. Is a stone causing gallbladder disease or cholecystitis more likely to be taken out than an calculus one?
I think that's a moving target in a lot of ways, right? So surgery has these guidelines they go by, and Tokyo guidelines from 2018 are one of them. And then there's like a Western Congress guidelines. A lot of what they're looking at and what surgery seems to be kind of going towards is allowing for the gallbladder to cool down. So they kind of grade severity of cholecystitis, like grade 1, grade 2, grade 3. So not all cholecystitis needs surgery. Not all cholecystitis needs a tube, right? So some of these patients can be managed just with antibiotics. And then the ones that are not doing so great, the white counts greater than 17, 18, the ones who are septic, the ones who have other issues, then become a toss-up of, do we temporize them, which is what surgery likes to do, by placing a gallbladder tube in and allowing them to kind of coalesce. Now, the timing for surgery isn't actually standardized. So sometimes people say, listen, we're going to let them cool down for 6 weeks. Sometimes we'll let them cool down for a little bit longer. So unfortunately, when we talk about cholecystitis secondary to gallstones, it's just potentially intermittent obstruction of that cystic duct. So when we see these patients back, if we see a nice gallbladder full of stones again, it's hard to pull this drain out until they get surgery. So sometimes we just maintain these drains on people because we want them to be healthy enough to get to surgery. And so that becomes kind of a nice point. We like to see that surgery has seen the patient while or in tandem of us putting in a gallbladder tube. The reason is not really at that moment what we're going to do, but really what's the disposition for these patients? Because we have patients sometimes who have drains for, I think 1.5 years, 2 years, because surgery hasn't wanted to take this out. And so there are, studies that find that once patients are above like that 75, 80 years old, a lot of these patients are tubes for life, which is a really kind of long conversation before we put these drains in for people. A, to make sure they absolutely need it, but B, for them to understand that unfortunately this is a forward facing tail that they're going to have for an extended amount of time.
Well, I'm just going to ask you one quick follow-up question, then I'm going to let Adam go. And it's just the four of us here, so no one's listening to this anyway. Do you ever tell surgery that the gallbladder has cooled down by using some fancy radiologic term that they don't understand? No. Okay, gotcha. Okay, just checking. Okay.
There's no winning that argument whatsoever.
How do you know what is cool? What is cool?
I have no idea. Because half the
knows.
time I look at a CT and I'm like, this looks great. Take it out. The patient's 30 years old. They run all day. They have a great BMI. What's the problem, right?
And
I hear that it's got to cool down. And I'm like, if this is not the most ideal candidate for you to just boop the gallbladder out, I don't know what to say. But granted, I'm not a surgeon. So
next time just tell them you've used some radionucleotide dye or something. Just say that.
I wish.
Just try it.
HIDA's for everyone.
There you go.
All right. I'm going to jump in. I'm going to steal one of your questions, Hanny. So I think that's a good point. And maybe you guys don't have an answer. Is what is the ideal patient to you guys that should just go straight to the operating room? I know you guys kind of alluded to it, but when you hear something, you're like, oh, just call surgery. This isn't us.
I mean, so from our standpoint, the question with acute cholecystitis is there a concomitant biliary obstruction? That's generally the question for us when the bilirubin is elevated or it looks like, bilirubin alkaline phosphatase being elevated. Sometimes that's just what we call a Moritzi syndrome, where you actually end up with either gallbladder or stone in the gallbladder neck or in the cystic duct, and it's actually pushing externally on the bile duct. That's a different story. Unfortunately, from a GI perspective, we're not able to really handle or at least address that issue because it's not really within the main bile duct. So that's one thing, that we usually like to at least defer to our surgical colleagues about. Unfortunately, if there is no biliary obstruction, there's not a whole lot for us to do from a GI perspective. If they do have those lab findings that are abnormal, meaning that bilirubin elevated or alkaline phosphatase elevation, then we end up doing further investigation, whether it's with an MRCP or if it's an endoscopic ultrasound to actually see if there is a stone present as well.
Got it. Sorry.
I saw a Randy question just came up. Yeah.
I had a quick trigger finger there. But I did want to pop this up. It's kind of relevant. And since this entire episode is dedicated to Randy, should we pop this question? Since I already popped it up anyway.
Let's do it.
All right. In the ED or the ICU, often at the diagnosis of acute cholecystitis, a surgery bot is activated first. In your perfect world, who would be the first contact in a septic gallbladder?
But before you guys answer, I just want you to know we're really proud of this feature where we bring questions in and we put it on the screen. This is something we've been working forward to. So let's just appreciate it.
We're like kids with new toys. So
yeah.
Good job, Randy.
Good job, Randy. All right, who wants to take that one?
I could honestly say that a lot of times we pick up the phone and we're like, did you call surgery? That's all we really want to know. Honestly, ideally, we get kind of the consult almost at the same time as surgery because I think the algorithm is really having them hold off on a lot of these gallbladders. I'd rather not wait the 6 hours or whatever it is while we hem and haw if this patient is truly septic. Also, because if they're truly septic, there's things that we want corrected. There's lab values. There's things that we kind of need in place for an acute chole. So if they're going to take them, that's great. But if this patient is septic, I'd rather just get it over with and stick the needle in. I do want surgery on board, like I said, because A, if we can't do it, if there's some anatomical reason we can't do it, if it's not going to be safe, we've got a liver full of cancer, whatever it may be, carcinomatosis, ascites, things that we all look at before we stick a perc chole in. those things I do want surgery involved in. But more for the dispo issue. If I'm consenting a patient, I want them to know whether they're a surgical candidate now or ever. Because if they're never going to be a surgical candidate, the conversation shifts a little bit. Like, hey, listen, I will see you in perpetuity every 6 to 8 weeks. Like, welcome to IR. I'll see you in the basement. It's a different conversation. So I'm happy to get the consult almost at the exact same time, only because we can kind of work in a team and figure it out together and have kind of a cohesive discussion with the patient at the end of the day.
Makes sense. And have you all ever thought about creating an ABRT? This is genius.
Those
Ready?
are some really great
Ready?
initials. What
Ready?
are you about to call this like a code team where we get all paid?
An acute biliary response team.
Oh,
Everyone
yeah.
collapses on the patient.
Big fat no, we have not.
All the way from the basement. All the way from the basement comes the interventional radiologist. Rushes to the bedside.
We've got two teams, and that's trauma and PE.
Is it true that IR considers themselves the first floor and everything else is above the basement? No? Okay, sorry.
No, we're in the dungeon of we're in
the dungeon.
In the bowels, literally the bowels of Cooper. We're never getting out.
I think every IR suite is down there, so don't feel bad. Don't feel bad.
No, listen, in training, we were on the 4th floor. We were living it up. Now,
one day you will rise. One day you
Yes.
will rise.
Us and our heavy machines. I don't think it's happening, but we'll see.
Adam, you got one?
Yeah. So where should we go? So we've been picking on surgery a little bit, and let me ask you the question then. What does the phone call sound like? And I'm talking about cholecystitis for each of you, where you hear, the fellow or the attending or whoever calls you, and you're like, okay, this is me. I'm coming in. Like I need to do something. So and ideally, let's try to keep it as ICU focused as possible. The critically ill patient, what makes you excited? Like, yes, I think I need to come in and do something for them.
I can honestly say for cholecystitis, that's usually not me. I'm hands off on cholecystitis unless there's any type of biliary obstruction.
I was going to say, a stone with dilated biliary duct, right?
Exactly. But that's, in that case, we need to decompress. So if there's question of that, particularly if there's jaundice, we're saying we need either an ultrasound that's showing choledochal lithiasis, so there's some type of stone present there, there's some type of stricture, whatever, then we'll go in. But for strict acute cholangitis, unfortunately, I don't have much to offer.
Acute cholecystitis.
Yeah.
Correct.
And Sabina says, I'm never excited about acute cholecystitis.
I mean, not to say that I'm never excited, but to be honest, there's very little that they have to say. It's usually, hey, I've got an ultrasound and a HIDA or something or other showing cholecystitis. Surgery is not operating. And then I've really got no leg to stand on. Unless anatomically there's an issue.
So that's the next question then. Let's talk about that. So then let's talk about that. What makes him not a candidate from your perspective? Even if it means potential demise.
All right. So I think there's kind of two ways to think about it, right? There's the labs and kind of the medical stuff that we can correct. And then there's the anatomic stuff that I can do nothing about. So lab wise, we'd like to see platelets above 50. We'd like to have an INR that's closer to 1.7 or lower. So if you're calling at 4 a.m. with an INR, which happened, I think a couple weeks ago, INR of like 5.6 and platelets of 10, I'm not excited to do anything. Y'all aren't going to be excited to do anything. Everybody's not in a good spot, right? So platelets of less than 50, we're not really loving it. And for some of these patients, if you're seeing INRs of 5 and platelets of 10, we've got a long way to go before we're going to be able to transfuse them to perfection, right? These are people that are sick and are eating things away and their livers are not doing what they need to do. So that becomes hey, listen, we're on board, but we're not there yet. On the other side, there's anatomic things that sometimes are just really not much we can do about it. So patients with liver tumors are problematic for us because we really do try to put the per chole drain through the liver parenchyma and into the gallbladder to help anchor it, one, and two, to help provide kind of a little bit of a tract for bile leakage just in case this drain gets pulled. So if there's liver tumors, we do not like going through liver tumors with a drain. A, because liver tumors bleed, and B, because we can seed them all over the place, though the risk is quite small. Ascites is also not a great thing for us because it allows for movement of this tube. And when we move the tube on the inside based on something that we can't control, you can get tube dislodgement and, again, bile leakage. Bile leaking into the belly does not feel good. So bile peritonitis is not a good way to go. Everybody's upset, more so the patient than anyone else. So those are the things we're really looking at anatomically. Can I get a needle from the skin and into the gallbladder, ideally through the liver? And if we have to go transperitoneal, is the colon in the way? Is there other things in the way? Carcinomatosis, we don't love going through. If it's a bunch of ascites, sometimes we'll drain the ascites, but if it's someone who's a rapid accumulator, it just leads to kind of some problems in the long run.
Interesting. And just a follow-up question to that, how do you monitor those? Someone comes back from IR, they come back to the ICU, we're watching them. What things should we be looking for on a daily basis for those tubes, even though you're following as well? What should we be looking for? And how often do you do another sort of a cholegram or a
cholangiogram? Yeah.
Cholangiogram, yeah.
So once we put that tube in, they go into our nice little follow-up pathway. We will see them usually around that 6-week mark, and then unfortunately until we take it out or until they go to surgery to get it taken out in tandem. As far as what y'all should be looking for, in reality, if we take someone who was sick but not, quote, septic, the thing that I worry about anytime we instrument anything and cross that barrier is that we can push them into sepsis, right? So every once in a while, we'll give you guys a call saying, hey, FYI, I know they're headed back to the floor, but, I would keep an eye out because we have some rigors happening, we have fevers, where we might have pushed him into sepsis or her into sepsis. So if you watch out for that. As far as what you guys should look at for the drain, we just want the drain flushed in reality. Like, keep the drain patent and we're happy-go-lucky for the most part. The output of the drain can sometimes go up and down because if it's intermittent cystic duct obstruction or there was never a stone there to begin with and the inflammation goes down, the patient, if they have a cystic duct that might be patent, might be draining the way they should drain. So the amount that comes out in your drainage tube doesn't necessarily mean that it's not working, dislodged, or whatever it may be. It just means that just maybe it's draining the way it should be. But if you're ever concerned about dislodgement, a quick right upper quadrant ultrasound to take a look at the gallbladder is the easiest way to do it.
Excellent. Krysta, let me ask you, emergent ERCP seems to be rare, right? But does happen. What does a patient really have to look like, or what lab tests are you doing clinically? What does that person have to look like for you to get out of bed and come in and do an ERCP?
So this is a bit of a tough situation to be in because you really have a very narrow window a lot of times. So you generally want to decompress within 24 hours. The problem is that especially people who have gram-negative rod bacteremia, can get really, really sick really, really quickly. So you want to try to decompress as soon as you can. I mean, things that we're looking for to really make that diagnosis of cholangitis, so fever, right upper quadrant, pain, and jaundice. We're looking for the elevated bilirubin. We want imaging that's going to tell us that we have, a dilated duct as well, maybe choledocholithiasis. Sometimes that's not the case. But in these patients, you want to try to do it when they're stable enough. So it's important to first treat the sepsis. Just remember, anytime we do an ERCP, it requires us to put the patient under sedation. Of course, anytime we put the patient under sedation, we're going to drop their pressures further than they are. And if they're already septic, they're probably bordering hypotension anyway. So trying to get them stable first is the ideal situation. So trying to give fluids, trying to give antibiotics, you want broad spectrum coverage. For sure. Then we want to do that before we actually take them to the operating room. Generally speaking, sometimes we do these patients under MAC anesthesia. Sometimes they require intubation. It really depends. But you have a very narrow window. You really do. So trying to optimize them, from our standpoint, it's similar in terms of coags. What we're looking for, we want that INR ideally 1.5, 1.7 is okay. Platelets above 50, because when we're going in, we're instrumenting the biliary tract too. So it's the same types of things that Sabina was talking about. Anytime we're going in there, we're injecting dye as well. So when we flush dye up into that duct, we're actually risking sepsis for that patient as well. So trying to minimize the amount of dye we're flushing to really cause that infection to drive up further into the biliary tract is a big issue. So we need to remember that as well. So that, I would say, one thing that we should always be upfront about when we return the patient to you in the ICU is that, yes, that can definitely happen. Things can get worse before they get better. Things that we try to do in terms of relieving the obstruction. If it's a stone, we go in, we try and actually remove the stone. There are times when we cannot remove the stone. If we can't remove the stone, and especially if it's a very sick patient, we're trying to minimize the procedural time that we actually need. Sometimes we'll just put a stent in to bypass the stone and get out of Dodge. Same thing if it's a patient who has a biliary stricture for whatever reason, whether it's a benign or a malignant stricture. Those can be very difficult cases too. And the whole goal at the end of the day, when we're doing this in the middle of the night or in very in urgent fashion, is to decompress. If you can get them decompressed and get them over the acute illness and help them to actually drain properly such that they have source control, then we can go back in a week, 3 weeks, 5 weeks later, whatever it may be, to exchange that stent. Or at that point, if we really have been unable to remove the stone, that's when we go back in to remove the stone as well. You're just looking for drainage.
And just walk me through when you're putting the stent to bypass the stone. Could you just tell me where exactly you're putting that stent?
Sure, yes. So when we go in, so we're actually going into the duodenum. That's where your ampulla is going to be. And then we cannulate up into the bile duct. So when we cannulate up into the bile duct, what we do is we float a wire up into that system. And then we use our instruments to basically make a cut. So we usually do a sphincterotomy. That helps us. Unfortunately, when we have really, really sick patients or patients who are on blood thinners, we can't make that cut in the muscle. Ideally, when we're trying to remove a stone, we need that to be open a bit more so that we can remove the stone in its entirety. So, for example, if someone was on Plavix, we cannot make a cut in that muscle to facilitate that stone removal, but we can still put a stent in place. So that stent is going generally up into the common bile duct. Sometimes it goes up into either the right or left system, depending on where the obstruction is. If there is, sometimes people have cholangiocarcinomas, hilar tumors up higher. Those are very difficult cases for us too. Sometimes we have to get up to actually go into the bile duct and then into either the right or the left system, depending where that obstruction is. We're just trying to get past that blockage to get them over their illness.
Gotcha.
And unfortunately, these are times where sometimes we fail too, and then we, come to our interventional colleagues to help us out.
Yeah, and when you say ampulla, you mean the ampulla vater, right?
Yes, that is exactly
my favorite anatomical structure from medical school. I just had to use that at some point before I retire. Okay, thank you.
You're very welcome.
Adam, what do you got?
So, I guess it's my turn as we're all staring at each other. So, you guys have both mentioned it. I want to tell you from the intensivist standpoint, when we send that patient down, there are probably two flavors that we get excited about. The one that they come back and the pressors melt away. And probably second is the one that comes with escalating pressors. And it sounds crazy, but those are the ones who are like, okay, we got it. We know it's the gallbladder. It's the ones that go down, they're sick, and they come back and they look the same. Those are the ones that I'm like, oh man, like either we got the wrong diagnosis or we don't know. Right. And so I think that's important to mention. And it's probably, we should have said this in the beginning. It's so frequent where they're sick. We know they're sick. We're worried about the gallbladder. And so sometimes I know we ask you guys to do things that may not seem totally logical, but with no other explanation, I do think sometimes you got to blame the gallbladder. So my question is about imaging. So are all of these imaging studies just ways to delay and get you through the night so then the next guy can come in tomorrow?
Jeez,
Or
it's cold.
so why do we have there's just all these letters? Like what ultrasound and CT, like when do we use which ones? MRCP, like what's the deal
Haida.
with all these? HIDA, yeah.
That's a great question. So, ultrasound is what we like to see because it gives us kind of the best information. It's a sonographer that's going to be actually pushing on the belly. We can have an idea of a Murphy sign. We can have an idea of what the gallbladder even looks like. If it's completely decompressed around a big old stone, i.e., like a Maritzi thing, there's not much IR is going to be able to do about that, right? We can like stick a tube next to the stone, but it's not decompressing anything because the gallbladder is not full. So we look at the ultrasound for those types of things. Often the ultrasound is equivocal, right? Mild gallbladder wall thickening can be seen with a lot of things. If you have anasarca and ascites, you can have gallbladder wall thickening. That happens, and that's okay, right? You can have stones, you can have sludge. Like these are all normal people things, right? So we don't get so super excited. So in those cases, when we're kind of chasing our tails going, is it or is it not the gallbladder? We like a HIDA because it gives us an idea of whether there's acute cholecystitis or not. As far as an MRCP, I think that's when,
I'm
Krysta
gonna,
and
I'm
I,
gonna interrupt. I'm gonna interrupt and explain just for all of us
oh,
what
sorry.
in for the HIDA, what would make you think yes cholecystitis versus no cholecystitis?
If you do not see the gallbladder, you've got acute cholecystitis. If you
Okay.
see the gallbladder, not so much acute cholecystitis, and you can give stuff to see it go through. And sometimes it's not the gallbladder, right? So a lot of times we hem and hawk and we're like, listen, I don't want to put a tube in this person that's going to be in there for 6 weeks. If we're really not sure, do you mind getting a HIDA? So theoretically, is it a delay? Yes. But in reality, if the person is not super, super sick and we have time to do a HIDA, it's often the best maneuver because there's a lot of times where we will not have to put a drain in and something else is actually the issue. As far as an MRCP, I think that's when Krysta and I's team come about because then we're looking at not really just the gallbladder, but mainly the biliary tree in and of itself and gives us a good picture of what's going on with the liver. CT is so commonplace. I think it's the new kind of physical exam in a lot of ways. And it'll be like the CT shows acute cholecystitis. CT is not what we use to diagnose acute cholecystitis, right? Gallbladders can look all sorts of funny on a CT. So we want to see that ultrasound. So I think ultrasound and plus or minus a HIDA is really what we prefer. An MRCP if we need to know if there's something else going on.
I'm going to
Great,
add
great.
one more
You
thing.
know, I
Sorry.
do want to say I need to apologize. I wasn't implying in any way that you would delay care to get rest. That was uncalled
We
for.
know, Adam. We know
And
what you're trying to say.
It's all right, Adam. I only answer Haney's phone at 3 in the morning.
and the second request, we don't actually call it CT on the show. It's called the Truth Box. Okay.
Okay.
So all right.
Hopefully that truth box gets read in a timely fashion.
Yeah.
Do you think if a robot hand came down while the CT was happening, that could really be a new physical exam and like look
It
for
really
Murphy sign
could.
during the
Murphy sign.
Yeah.
Okay.
Okay.
Sorry, Chris. After interrupting you.
No. I was just adding one more, imaging study that we sometimes use, which is endoscopic ultrasound. So generally speaking, when people are super sick, we don't do that because it again is a test that requires anesthesia. But sometimes, when people aren't super ill and they have some type of contraindication to getting an MRI, sometimes we will do an endoscopic ultrasound, which is basically a scope test with ultrasound probe on the end of the endoscope to look to see if there are any stones or any type of other abnormalities of the biliary tree. So
Cool. Lots
generally,
of cool toys.
Because that's usually used for masses for biopsy, right? That would be
say somebody has a dilated bile duct or has obstructive jaundice, or we think that they have obstructive jaundice, and either we don't see something on another imaging test. Sometimes we'll do endoscopic ultrasound too. Generally, dilated bile ducts, happen for a number of reasons. So it could be stone, could be stricture, could be ampullary stenosis. in those types of situations, ampulla vater, by the way, stenosis, those would be reasons we would do endoscopic ultrasound, because, ERCP is not necessarily a benign procedure either. Anytime, we do that, there's of course a big bleeding risk, but pancreatitis is another problem with that. So the pancreatic duct and the bile duct run alongside of each other. So, if we're doing it, we have to make sure that we account for that risk too.
I have to ask, I know this is completely off topic, but you mentioned complications with ERCP. Did you hear about the drummer from Blink-182, Travis Barker? He had an endoscopy.
Courtney's husband?
Yeah, Kourtney Kardashian. Not that I know anything about the Kardashians.
Not that you know anything.
But I'm just saying, I read that somewhere. I mean, it's on the news, so this is no HIPAA violation, but what do you think happened? Like, it was just bizarre. He had this endoscopy for some reason, and then he had this whopping pancreatitis. I think that landed him in the ICU.
So
as you read that, yeah, what do you think?
It's not super common to see, pancreatitis. It doesn't happen every time, and there are certain people that are higher risk than others to develop pancreatitis. So a lot of time, people who have cancers and, underlying malignancies where they have biliary obstruction, those patients are less likely to actually develop pancreatitis. People that have gallstone disease, some of these individuals actually have pancreatitis because of gallstone disease. People that have, retained stones, people that have other things like sphincter of Oddi dysfunction, they're at higher risk actually to develop pancreatitis too. So sometimes, because it literally, the pancreatic duct runs this way, the bile duct runs this way, we're going in and, threading wires and injecting dye and so forth. You basically tickle the pancreas, you can create inflammation there. So we do various things to try to avoid pancreatitis. So one thing is, if we're in that pancreatic duct where we're not, ideally supposed to be, when we're trying to alleviate a biliary obstruction, we put a stent in there to make sure that the pancreas still drains. Sometimes we actually use rectal indomethacin, which helps to decrease the risk of pancreatitis too. So
what?
It happens, and basically
you use what? Rectal
indomethacin, yeah.
Oh, I thought you said, I don't know. I thought I heard ivermectin. My bad. I was like, this is not that type of show. We're not conspiracy theorists, okay?
No.
Okay. All right. That's super interesting. Did you know that, Adam, that Travis Barker from Blink-182?
No, I didn't. No.
Yeah,
no,
he got really sick. Yeah, you got to watch
I'm
more.
I'm not up on my pop.
You got to watch
culture.
more of the Catching Up with the Kardashians. That's all I'm saying.
Yeah.
Okay. I got one last question, and then we have a bunch of questions. If you ladies have time to answer some questions. My last question is, in pregnancy, and just take it to the second or the third trimester, does this change anything in the management of the approach? Of course, having an ABRT would help you to manage this if you guys develop that, and you can thank me later. But does that change anything in terms of who gets called first, or is it still a joint sort of decision?
For acute chole or acute cholangitis?
Let's go with acute chole in the later stages of pregnancy. But someone's
acute
sick.
chole is, I'm assuming, not likely going to be Krysta at this point. So acute chole in pregnancy is unfortunately going to end up being an IR thing. Surgery is probably not going to take that gallbladder out. I feel like that woman has other stuff going on at that moment in time and probably doesn't want her belly cut open at that moment in time. And that's fine. We just there are certain things that we like to do, i.e. see where we're going with live x-ray. And so that becomes a discussion, an informed discussion with the patient, and then certain meds that we give. Like Krysta said, we sedate these people. We do a little bit of a different sedation in IR in comparison to GI. And so most of our patients are on moderate or conscious sedation, like Versed and fentanyl. And then our non-dilated biliary system, i.e. when Krysta and I's teams collide, that sometimes we need anesthesia as well to keep it comfortable for the patient. But I can say most of our gallbladder tubes, we don't really use anesthesia unless there's really a big need for it. So sleep apnea patients who can't tolerate doing this without Versed and fentanyl, we would want anesthesia just there to help protect our airway if we snow them too hard. Otherwise, a lot of these patients will go through with just pain meds only if they can't have both. So for the pregnant woman, it's probably going to be us. So you might as well just give us that first SurgeBot call, like Randy was saying, and we kind of go from there.
Got it.
If it's
Great.
cholangitis, we're still probably going in and doing the ERCP. Ultimately, you're going to end up needing to decompress. So
Yeah.
it's a discussion with anesthesia, and again, we're using X-ray too. So again, a discussion regarding radial or X-ray beams.
And imagine the doses. If I remember this from trauma rotations, but you can pan CT somebody top to bottom. Not that you would in pregnancy, but you could under safe, fetal exposure. Um, is the doses of radiation that you're using for these particular procedures? This must fall well under the. Although it is kind of directed at the uterus, there's probably no way to shield. Is that right?
So we don't usually shield these patients a lot. In a lot of things, shielding is kind of counterproductive because it increases the X-ray dose to kind of see around it, or it continues to try to see through your shield. In reality, we're playing up in the right upper quadrant when we're really worried about like organogenesis and when the little boba is getting radiation. It's usually when they're quite tiny. And so at that point, we really should not be scanning the gallbladder at the same time with an X-ray as the pelvis, right? Now, once you get a pretty big old uterus and it's high enough that it is kind of in your right upper quadrant, at that point, that baby's mostly cooked. So a little bit of X-ray is probably not going to be the end all be all. But like I said, it's a conversation. We still disclose it to the patient, but we're not really worried about true X-ray dose. A chole tube can be done incredibly quickly with about as much X-ray dose as like a chest X-ray.
Oh, wow.
So in reality, I'm not too worried about a chole tube. A biliary drain in a non-dilated biliary drain to try to potentially put an internal external biliary drain through an obstruction, et cetera, can take a little bit more of fluoro time. But, if it's to keep the mom safe, it's to keep the mom safe.
Fantastic.
Yeah, same thing here with the ERCP. It's use the minimum amount of fluoro time you can. But we do try to shield. But the least amount of time, the least exposure, the better.
Adam, do you have any other questions, or should we take some from the audience?
I actually have one more, and it's always perplexed me. You have the perforated gallbladder, and you will still see someone put a drain in. And I guess my question is, I thought the whole concept is that it's an organ under pressure that then you give an exit to. So if it's perforated, that never made sense to me. I guess there's continued bile production until you're preventing bile peritonitis from it, or what's the role of that?
Actually, I have a sound effect for that. Just listen.
I totally agree. That exactly is how I feel.
Okay.
So
Okay.
reading through what gangrenous cholecystitis is and perforated cholecystitis, I was like, nailed it. I don't have to touch this. This is going to surgery 100%. Not the case, apparently, right? So once it's gangrenous and or is perforated and there's a liver abscess, they're not keen to go in. So now a perforated gallbladder means I'm putting two tubes in, one into the gallbladder and one into the liver abscess, right? These people are miserable. They do not like it, but I don't really have a choice. So unfortunately, gangrenous cholecystitis really should be going to surgery, but if they're, quote, too sick to make it through surgery, they're getting a drain.
Okay. Right. I understand.
All right. So let's take some questions from the audience. Let's do this because we have this ability, right? Got to use it, pay for it. Is there a different threshold for intervention, whether surgical or less invasive, for an immunocompromised patient?
I think that's a good question, right? So if these patients have low platelets, have kind of issues in that realm, I think it's a problem for both of us. Mm-hmm. If they're immunocompromised because they're on active chemo, then it's a pretty long discussion with us in surgery. Surgeries where they're not going to heal, and rightfully so, right? Chemo kind of hinders that ability. We're worried about putting a drain in that can serve as a nidus of infection after the cholecystitis is done and over with, right? Because these patients are on active chemo and are immunocompromised. So it is a discussion between, if it's immunocompromised secondary to chemotherapy, then it usually involves us, hemonc, and surgery all at the same time saying, is there going to be a right time for us to take this out? are we pausing chemo? Is this going to affect their chemo regimen? If it's going to delay their chemo, or if they're not going to give chemo because the drain is still in, then a lot of times surgery will kind of say, listen, maybe we need to go in earlier, or maybe we just need to take it. They don't launch a white count often. And that's kind of the major issue, because one of the main reasons we come into play is because they have this skyrocketing WBC count. And for some of these patients, they don't do that. So it becomes a little bit of a conundrum in that realm. So is there really a different threshold? Not so much, as more of a discussion, like a multidisciplinary discussion in an immunocompromised patient.
Great, Krysta. Any considerations on your end?
Generally speaking, so with any endoscopic procedure, neutropenia is always a big thing. So they often want us to have the ANC more than 500, ideally more than 1,000 though. So, anytime basically put any instrument into somebody, you're at high risk for infection. So I think from our standpoint, really it's the neutropenia issue, and we end up speaking to the oncology team prior as well.
Okay. Anyone can take this next one.
I thought I said it.
Yeah,
it was actually
she did.
Amazing. He wrote it. He
wrote it, and you said it.
And then you said please, and then you said it was like bam, bam, bam. It was amazing.
All right. Okay. Calm down. All right. Sham's asking, what about antibiotic coverage? Do you just, with all due respect, do you just sort of hand it over to intensive care and say whatever you all think? Or do you have some strong opinions about what you should be using for, let's say, ascending cholangitis?
Yeah, I mean, I think gram-negative and anaerobic coverage is the big thing. But generally, these people are so sick anyway, you end up covering, gram-positives too. So I think you never will be, you'll never regret your decision if you have somebody that's that sick and you put them on broad-spectrum antibiotics. You can always de-escalate later, but we're generally of the mindset, go big initially and then pull back after you've decompressed.
I just want them to be on antibiotics. If I'm the first person putting in antibiotics, that sucks in a lot of ways, but we do it, right? So if they're not already on antibiotics, they get IV antibiotics as we're putting the drain in all sincerity. So whether they're on a regimen or not, they're getting something with our team. If they're on a regimen, then we usually won't add stuff, but they need to be covered. If they're sick enough to need a chole drain, they should be getting antibiotics.
This might be a stupid question, but if someone is in the intensive care unit and says this is going to be gram negatives, I'm covering them for gram negatives, arguably maybe they should be on broad spectrum. But if they don't, and you're just about to start their percutaneous procedure, do you feel the need to cover them with gram positives, like peri-procedural? Like, is there an ANSEF? Is there an ANSEF for IR? Is what I'm saying, like ortho has.
So ANSEF flows like contrast in IR. Why? Because we break the skin open to do everything and anything, right? So ANSEF is like the golden goose, because anytime we're worried about skin flora when we're going in, that's what we're using, right? So ANSEF is usually our go-to for like a port placement or, something like that. That being said, for urine and bile, we like to see antibiotics that really do cover the things that we're worried about. Now, am I going to give this person ANSEF in addition to whatever they've got going on? Probably not, because they have some antibiotics on board. But if you come with nothing, you're not probably getting ANSEF. You're probably getting something that covers the gram negs.
Yeah. Haney, there's more to the question. I think it's a really fascinating question, in that we talk a lot of times about double gram negative coverage, specifically with hospital-acquired pneumonias, right? And I think that's probably a controversial enough topic, but it is guideline based right now. Yet we never talk about double gram negative coverage in other sources of infection. So, I think if I have someone with a gallbladder pathology that's dying, I guarantee they're getting a dose of Gent. I guarantee I'm going to give them an additional gram negative coverage on top of their Zosyn or Cefepime or whatever else you've chosen.
100% agree. Those are the people that I find myself giving. People who have a stone with hydro, or like you said, the biliary tree, those are people that are definitely getting gent if they're hypotensive before they go to the procedure, because there's always that chance that they get worse. And one dose of gentamicin is going to hang around for a while. And look at us getting all nerdy with antibiotics right now. Isn't
There
that
you
fun?
go.
Yeah.
I'm a Zos fan, right? Gentamicin, we'd have to go look for that downstairs,
Yeah.
right? There's only so much that I can stock down there. So Ansef,
BRT team.
yeah,
That's right. That's for the
Ansef,
ABRT.
Sosin, all that kind of stuff down here. Gentamicin, I'm looking at you guys to add to the regimen for sure.
Sounds
like
great.
I said, we don't want to keep them down with us very long. So my whole goal in a cholecystostomy tube is get them back upstairs within like a 20-minute, 15-minute procedure, right? The procedure for a chole tube really should be less than 5 minutes.
Wow, that's impressive. That's impressive. Well, any final thoughts before we let you all go? This has been, by the way, a fantastic talk. This has been one of my faves already. But any parting thoughts, any things, I guess I should ask you, any things that you'd like to see emergency medicine / critical care, or the intersection between the two, be doing more for the patients before they get to you, or things that would be helpful, data points that you would like to see us get before we give you the call?
Let me paraphrase. What do we do that drives you crazy, and how do you help us
It's
stop
a better
doing
way
it?
of asking that question.
We ask everyone this question.
I think we really need labs and you need imaging.
Yes.
I think that's like that's like step one. So if you have labs, even if it's, labs and an ultrasound, that's pretty quick. It's hard to, get the call just when, for example, somebody has jaundice and a white count. I think having that ultrasound is so important because, that kind of guides us in the next step. So that can be, somebody who has decompensated liver disease with SBP, or it could be somebody with cholangitis. So I think ultrasound, we're talking about biliary or gallbladder pathology, labs and ultrasound. And if they look sick, antibiotics, fluids, and management from the sepsis standpoint.
I think for me, it's probably the same. We're imaging guided docs, right? So imaging is really our key. If you have an ultrasound, that's great. If you can make sure the platelets are above 50 and your INR is 1.7, it's a whole bunch easier for me to have a chit chat, right? Because whether we know, and we get these calls a lot, especially at the beginning of the year, like, hey, something needs to be decompressed, or hey, something is going on in this general area. And so we get a call, and it might be the gallbladder, but it might be the biliary tree, and it might be jaundice from tumor. We get all the same call. For us, it's just, hey, help, drain, which is fine. But it's a different conversation when we know what the imaging shows, so that we can kind of talk to you guys and the patient about whether it's a PTBD, which is a biliary drain for the bile ducts, or a per coli, which is a drain for the gallbladder, right? And then we can kind of talk it through. Labs are key. And ideally, if they can be NPO, so that I'm not trying to shove this thing in while they are screaming at me, we like it better, right? So most of these patients are NPO because it's the gallbladder, but not so much the case with kidneys.
That's great. And
I'll add one more thing.
Yeah.
I'll add one more thing in the era of COVID. Rapid COVID test is another thing that helps us out a lot from a procedural standpoint. So.
Yeah.
Well said. I will say that's one thing we're really good at, the emergency. Everyone gets a COVID test now. All right. Well, one last thing, just not to throw shade, but
I know I saw this.
I'm just saying, if you were to start an ABRT, you'd have a lot more power in the hospital. You could be even in the C-suite, right next to the.
Listen, we're on the 4th floor at MD Anderson. Okay. So across the street, IR is on the 4th floor. It's just the bowels of Cooper until we get that fancy new building that we're talking about, where I was promised we wouldn't be in the basement, but I feel like they were just saying that to say it to me.
Krysta's upstairs, right? And so maybe you guys can be right next to each other.
Oh, yeah. There you go. ABRT together.
It's catching on. You guys laugh, but it's going to catch on. It's going to
Listen, if we can call you every time we get called,
yeah,
then that's a deal.
Deal. All right.
That's easy.
I'm not sure you want to take this deal.
Oh,
but...
come on. I'm up anyway.
Exactly right.
I'm up anyway. So we might as well do this and get matching t-shirts. It'll be great. All right. Well, thank
see.
you so much for being on here. I really do mean it. This has been one of the best ones that we've had so far. Really nice discussion, and mostly you taught me a lot, and I'm sure many of the listeners too. Don't forget, folks, to like and subscribe. You could still ask questions in the chat. We'll direct Krysta and Sabina to look at the chat maybe later on. If there's any questions, we might just send them to you, say, hey, do you mind answering these questions? But we've taken a lot of your time, so we really do appreciate. Adam, any parting thoughts?
No, that was wonderful. I learned a ton. That was a really great episode. Thank you.
All right. Well, thank you so much for being here, and we'll see you around the coop.
All right,
Okay.
sounds good. Thank you guys so much. Take care.
Thank you so
Bye.
much. Bye.
Krista,
Have a
see you
good
soon.
I'll see you very soon. ABRT for life. Here we go.
ABRT for life. Here we go. Bye, guys.
Bye, guys.
Dude, wasn't that great?
Yeah, that was really good. I'll tell you what surprised me. I knew it was going to be all about imaging, but I was really impressed with the amount that the white count matters, that the clinical findings matter. It surprised me they mentioned Murphy sign multiple times, and I just, I've always said, the pleural space is my favorite part of the body, that, and I've always can't have an empyema without having pain back there, and it kind of sounds very similar, like I was, I liked that part of it.
Yeah. So even though there's no Murphy sign for the pleural space, you still liked it.
Yeah.
Okay. Is there any sign in the pleural space that you can push on? Do you do agaphony?
So I was hoping we would talk about how great the episode was, not just my
agaphony,
my love for the agaphony.
Or what's the other one? I forget all those physical
Tactile
examples.
fremitus.
Tactile fremitus. That's the other one. I mean, you can just tell me. It's all BS with ultrasound, right? Like, are you sitting? I mean, come on, right? When's the last time you did tactile fremitus?
Oh, come on. Okay. Never.
All right, good. Just not for the medical students. If you're a medical student, we do it every day, multiple times.
That's right.
Yeah. Let's see. Randy is like blowing up the chat here. Production value today was excellent. Okay, that's good. The first thing the cardiologist asks is, do they have chest pain? What does that mean? It's cryptic. Randy being Randy. Well, Randy, thank you for whispered. Here.
If that's not a good time to end it, I don't know what is.
I don't know. Well, listen. Adam, thank you for putting together a great show. What's next on our agenda?
So, we don't actually have it locked down, do we? I think
not exactly.
Emails,
but what are we going for? Like, we have an idea.
The goal is temperature targeted management. I think that is the goal. I'm not going to call it hypothermia, and I'm not going to call it cardiac arrest, because I hope we can dive into some other disease pathologies that benefit from temperature control. So that's the goal.
Okay, perfect. Yeah, and that's we're on a schedule now, so really should be 2 weeks from now. But check your social media. Check, don't forget like and subscribe, so you always are updated when we're going to be going live. But 2 weeks time, we'll be back again, and then I think the next time Adam is going to be here in the studio with me. That's going to be my goal, for sure.
This was, the entire reason I agreed to this was so I could hang out with you. So
no, that was the reason why I agreed, so I can hang out with you.
Oh, no way.
Oh yeah, way. All right, cool. All right, Adam. Good seeing you as always. And folks, thank you for watching. Again, like and subscribe, and we will see you next time on the Critical Care Lounge.
Absolutely. Thanks, guys.